Ladies and gentlemen, please welcome Dr. Wendy Green.
Good afternoon. It is my pleasure to introduce this afternoon's Peter Saffer Memorial Lecturer, John Bradley Holcomb. He graduated from medical school in 1985 and completed his general surgery training in 1991. From 2002 to 2008, Colonel Holcomb was a commander of the USA ISR and trauma consultant for the Army Surgeon General. Colonel Holcomb retired from active duty in 2008 and received the Lifetime Achievement Award in Trauma Resuscitation Science from AHA and the Service Award from American College of Surgeons. Dr. Holcomb is actively involved in clinical medicine, education, research, entrepreneurship, and is founder of a health IT corporation. He reviews papers from more than 25 journals and has been published in greater than 500 peer-reviewed articles. Please join me in welcoming Dr. John Holcomb as he presents the Peter Saffer Memorial Lecture, Military Lessons Learned from the Modern ICU.
Well, Dr. Green, thank you very much. It's a great honor to be here today. When you have a little bit of gray hair and you're asked to give a talk, sometimes you're allowed to change the title of the talk, and so that's what I did. So I was asked to give military lessons learned in the ICU, and we're actually going to talk about transport time, pre-operating room, hemostatic interventions, and how that might improve outcome after truncal hemorrhage. I have several disclosures. Now, in 2009, I was asked to give one of the plenary lectures. I didn't show up at the meeting in Nashville because my wife got sick and had emergency surgery. So when I was asked to give this lecture, I talked to my wife and made sure it was okay. I do want to recognize Max Harry Weil, Peter Saffer, and William Shoemaker. Dr. Saffer, this is Dr. Saffer's lecture. I had the opportunity to work with him in the Army, and he taught me a lot about hypothermia. Max taught me about cardiovascular resuscitation. And Dr. Shoemaker, who I worked for at LA at Martin Luther King Hospital, taught me about trauma resuscitation. Three giants of this society who I owe a huge debt of gratitude to. And then Kevin Chung, who actually should be given the assigned lecture. Kevin, I think, is in the audience someplace out there. I can't really see very well. There he is. Kevin, thank you. There's been huge technological achievements over the last 17 years of this war, since 2001 to today, which is ongoing. The deployed critical care teams are vastly better than when we started. You can see this picture is a picture of ECMO on a mobile stretcher in a tent. And ICU care, as Kevin has taught us and others in the room, is a team effort. It's a concept, not a place. You can do ICU care outside the tent. You can do it inside Ibn Hospital in Baghdad. And you can do it in an airplane flying across in between continents. So lots of improvements in technology. I would say that just for you all, many of you all don't know that the military went to war in 2001 without ICU teams. In other words, you had doctors in the ER and the OR, but no team in the ICU. And that still is in place in certain locations. So the military is catching up with that team concept in addition to the technological achievements, and folks like Kevin Chung and many others are leading that charge. Evidence from the literature on truncal bleeding. Why does that apply to this group of critical care folks? Well, I'll try to make that point. What does it mean for the teams as we go through history, epidemiology, time and cause of death, bleeding location, and potential solutions? This military-civilian translation that was the subject of an IOM, now a National Academy of Science report from 2016, is not a new idea. A book in my personal library on emergency surgery talks about what the translation from military surgery into the civilian world meant in World War I. So these ideas going back and forth from civilian to military, military civilian is a common theme, and of course we all want to learn from each other. This learning trauma care system is an important concept, well articulated in the IOM report from 2016, and we'll hit some of these concepts as we go through this talk and try to emphasize the value of data versus tradition. Now, just a little bit of epidemiology, not much as we get in the meat here, but injury is a really big deal. And for a lot of you folks, we don't need to emphasize that. But in 2010, there were 5 million deaths from injuries around the world, far outnumbering the deaths from HIV, TB, and malaria. Overall, the number of deaths from injury around the world has increased by 24% over the last decade or so. And the WHO says it will be a leading, if not the leading cause of death sometime in the next decade. Looking inside one hospital, this is our hospital. This paper was published by one of our medical students now 2 years ago, looking at just when people die. So 1,000 deaths. And you can see from the curve that everything happens very quickly. This bottoms out here. You probably can't read that really well, but about 4 hours after admission, and then is relatively flat all the way out for as long as you want to go, with 1 to 2% death rates per day on out here out to 40 or 50 days. Multiple authors have shown this pattern in their hospitals. It's not really new. The median time to hemorrhagic death is a little under 2 hours, important to remember. But 25% of the deaths, when you add up all these ones and fives and ones and twos and single digits, add up to 25% of the deaths. So appreciable number of deaths occur well into that ICU period. And I want you to remember that curve as we get to the end of the talk. Now, we've focused our efforts on bleeding control by multiple different methods, and we strongly believe in bundles of care, and so we created this hemorrhage control bundle of care, going all the way from identification and all the way through goal-directed resuscitation with blood products, starting at every little step along the way, trying to optimize each one of those steps from diagnosis, intervention, resuscitation, both with devices and with concepts in a team effort. And did it make a difference? Well, at least in this retrospective study at one hospital, but before and after implementing that bundle, it did. We decreased hemorrhagic mortality by 30% and overall death rate by 25%. How do we do that? Again, just to emphasize, not one intervention. Now, we've done, many of us have participated or led prospective randomized trials where you change one thing and look to see if that causes a big effect. In fact, the way we practice is we change lots of things and bundle them all together. And you just see some of this. Tourniquets, dressings, lots of blood products, hemorrhage control devices, and yes, we still operate on people occasionally. The whole blood down here and dried plasma and different components. Aaron Fox in our group, who's a really excellent epidemiologist, published a paper last year after our discussions with the FDA about endpoints of trials. And one of the key findings of this paper was in large prospective randomized or observational studies, in every one of them that had it recorded, the median time to hemorrhagic death was around that 1.5 to 2 hour mark. Now, that sounds fairly obvious. Bleeding people die quickly. But it's important to have an idea exactly what those numbers are before you start designing interventions and certainly prospective randomized trials. For those of you all who've been around for a while, you remember the 7A story. It's interesting in that the 7A prospective randomized trauma trial delivered the drug at 5 hours, meaning 5 hours. Well, if you remember the previous slide, the median time to hemorrhagic death was 2 hours. So in hindsight, maybe one of the reasons this didn't work is because the drug was delivered well after the median time of hemorrhagic death. Not something you'd want to do for a drug that's supposed to decrease hemorrhagic death. Shouldn't have done that. And so this gets you to start looking and putting together large databases, and this comes from the FARS database. This is pre-hospital and hospital deaths, 55,000 over 3 years. And what you see is you just take time to death, starting pre-hospital and in the hospital, and there's this pretty reproducible curve that starts appearing. And you start putting these curves together from all these different studies that I've mentioned, and you see that there's this consistent curve of death with a median time of about 2 hours. These are from 2 of our studies where we had high quality data measured minute to minute with observers watching exactly what was going on, not associated with the interventions. And then you step back and think about the golden hour now. So we'll change gears just a minute. The golden hour we're all very familiar with, when in fact this paper published in 2001 absolutely, I think, nails down the myth of the golden hour. It's a wonderful soundbite, but in fact not based upon any data at all. In fact, if you go back and read through this, what they say in 1979 is the mortality rate tripled for every 30-minute delay after injury. Every 30-minute delay, not a golden hour. I think it's probably a combination of logistics and reality back in the 70s when this was put together out of the Baltimore area. Eileen Bulger's written a very nice paper from the Rock Group that talks about time to transport and outcome. And there are multiple lessons in this excellent paper published several years ago, but the takeaway here is that the 43 minutes for ground transport and 76 minutes for air transport. So 43 and 76. I've looked pretty hard. I can't find that 10-minute pre-hospital transport time that people talk about so often. It's really hard to find in the literature. John Pryor, who's a trauma and critical care surgeon who was unfortunately killed on Christmas Day in 2008, was an author on a very nice paper, large number of patients, and divided all of these divided the time from injury to arrival in the hospital up into blocks, and the goal here was to optimize each part of that care. And the way he did it is said, look, you got to divide it up in these segments so you can figure out how to optimize each segment. And what John showed and Brandon Carr showed, the first author, is that the shortest time pre-hospital was 31 minutes and 76 minutes for the helicopter transport, very similar to what Eileen showed a couple years later. Now, out of San Antonio, the San Antonio group, and I hope some of the San Antonio trauma group at the university is in the audience, but put together a very nice paper with National Trauma Database, 2.5 million patients, looking at AIS 4s and above, significant chest and abdominal trauma, excluding bad head injuries, so patients that were at great risk of bleeding to death, and looked at pre-hospital time and mortality, so large patients and truncal hemorrhage. And what they clearly showed is that irrespective of mechanism, either penetrating or blunt, the patients that had the highest death rate between 0 and 30 minutes after injury. So 0 and 30 minutes after injury with 2.5 million patients was the peak time to hemorrhagic death, with very rapid decreases shortly thereafter. So if you take that same curve that we talked about earlier, 55,000 deaths, this is where in the Eastridge paper where you see the peak time to hemorrhagic death, this arrow is where our ground transport patients deliver patients to the hospital. The middle arrow is where helicopters deliver patients to the hospital. And the last arrow is the median time to hemorrhagic death after arrival in the hospital. So this slide, as we kind of go through the first 10 minutes or so of this talk, kind of lays out this conundrum. We're delivering patients to the hospital well after the peak time of hemorrhagic death. What does this imply for potentially successful interventions? Well, what should we do? Should we stay and play? Should we scoop and run, or should we scoop and play? So for my 30 years involved in trauma and critical care of these type of patients, it's been scoop and run. Scoop off the ground and drive as fast as possible, or fly as fast as possible to the hospital. That's kind of what we've been doing. And literally, after arriving in the ED, running, spending as minimal time as possible in the ED, literally running up to the operating room, running to the IR suite, and try to stop bleeding. So let's change gears and talk about some successful interventions in tourniquets and resuscitation. John Craig wrote a very important paper of our experience in Ibn Sina Hospital in Baghdad, published in 2008, but from data from 2006. 232 patients, 428 tourniquets. These are military casualties getting shot and blown up, and lots of tourniquet action going on. And you can see that if you put the tourniquet on pre-hospital versus in the hospital, the survival was dramatically different. So pretty simple idea. Do you stop bleeding from extremity? Do patients do better if you stop bleeding from extremities pre-hospital versus in the hospital? And the answer was yes. Somewhat controversial at the time, but not anymore. Shelley Skirbos, our T32 fellow, published a similar paper with 8 years of civilian data and showed exactly the same thing. If you put the tourniquets on in routine, everyday civilian trauma, pre-hospital versus in the hospital, you improve survival in these patients. I'm going to stop here. This is outside the talk, but this Stop the Bleed program that the SCCM is getting involved with, and other folks. How many of you all have heard of Stop the Bleed, the National Stop the Bleed? Wonderful. This program has just been incredibly exciting, linking together pre-hospital, laypersons, immediate first responders with critical care physicians, emergency medicine surgeons, on and on and on. And I think will absolutely save lives and strongly support it. So from a resuscitation point of view, I first learned about fresh whole blood in 1993. We published a paper in 2003 talking about whole blood and its benefits, hypotensive resuscitation, limited volume, minimizing crystalloid, things that nowadays have kind of become fairly standard by a lot of work from a lot of people. Single center, multi-center, retrospective, prospective, and randomized studies ongoing across not only the United States, North America, but around the world, where today it's fairly standard to give a balanced transfusion ratio to rapidly to massively bleeding patients and minimizing crystalloid. In the UK, this is pretty much the standard of care, and in the US, Jeremy Cannon published a review for the Eastern Association of Surgery of Trauma that suggests that the best outcomes are achieved by transfusing equal amounts of red cells, plasma, and platelets during the early empiric phase of resuscitation. And then you kind of say, well, okay, what about the time element here? Is earlier better than later? Should we wait until we know patients are absolutely massively bleeding, or should we start this earlier? And the best data comes from moving the same blood products from the blood bank to the ED or pre-hospital, and the patients do better the sooner they get the blood products, exactly the same blood products. And Dave Meyer published out of the proper database, every minute counts. If you have coolers of blood products coming from the blood bank to the ED or blood bank to the OR, every minute that they get there faster, the patients do better. So every minute really does count. And I think a stunning paper by Stacy Shackelford, who's an Air Force trauma critical care surgeon, published in JAMA just a couple of weeks ago, that pre-hospital blood product transfusion was strongly associated with improved survival in these casualties. So by putting blood products on the helicopter and transfusing them early versus in the emergency departments in Iraq and Afghanistan was associated with significantly improved survival. Again, earlier better. And finally, the Tactical Combat Casualty Care Group has long said, since 2014, whole blood and any of the blood components is there in their order of priority far outweighs any of the clear fluid, is much lower on their priority for resuscitation. And then the Israelis and the Germans have kind of led the way on dried plasma as a way to get around the logistics of cold storage and transport of blood products, and is their standard of care in their country for both military and civilian casualties. So is this spreading into the United States? Yes, it is. I tell you, in San Antonio, if you get into a bad car crash driving around and a helicopter comes, picks you up, you're going to get whole blood transfusion. That's the standard on the helicopters here as of last month. In Houston, Pittsburgh, Rochester, and Camden, New Jersey, the same thing, both pre-hospital and the hospital, and then it's spreading like crazy across the country. Whole blood transfusion, kind of a back to the future kind of thing. So 2 successful interventions, stopping bleeding early and transfusing blood products early. So early is the key. Let's talk about abdominal hemorrhage now. John Clark published this paper in 2002, looking at a large number of hypotensive trauma patients requiring trauma laparotomy out of Pennsylvania. The time in the ED was very short to very long, and looked at the overall survival of these patients and related it to time in the ED and time to the OR. And obviously the patients who were really sick, who got through the ED faster and the OR faster, did better than the ones who didn't, but still had a 40% mortality. So 40% mortality in hypotensive trauma patients requiring laparotomy. Most people are kind of shocked at that number and wouldn't think that it's as high as it is. So we went and updated this study recently, and I'll show you that in a second. But remember that paper that showed the peak time to truncal death was 15 to 30 minutes, right? That came from the San Antonio group. And patients arrive in the hospital between 37 and 76 minutes after injury. So those were the data that were kind of going on at the time when John Clark published that paper with a 40% mortality. And of course, now the bad news is when you do a current study as of last year at a large number of trauma centers and a large number of trauma patients, the mortality in hypotensive trauma patients requiring laparotomy really hasn't changed. It's still 46%. So in 20 years, we haven't budged the mortality in that group of patients who need to go right to the operating room. In this paper, John Harvin showed that the pre-hospital time was 51 minutes, right in line with what we showed before. The ED time was 22 minutes. People talk about getting out of the emergency department in 5 and 10 minutes, and it does happen, but the median is 22. And time in the OR is 14 minutes. That time of prep and drape and all this stuff has to happen. And then interestingly, the total time from injury to laparotomy started was 87 minutes. Kind of, if you add all that stuff up, you get pretty close to that. Ron Chang is a T32 fellow in our group, has put together data from one of our trials. This has been submitted and is under review. And as you would expect, earlier time to hemostasis is associated with improved survival, but also in this study is the time element involved. 67 minutes to achieve hemostasis in the operating room. So most of the studies that look at hemorrhage control stop upon arrival in the operating room. Well, for the surgeons in the group, anybody kind of thinks about it, hemostasis doesn't magically happen in the operating room. It takes a while, right? And sometimes it takes longer than others, based upon the skill of the surgical team and the injury pattern. So if you kind of add all this up, and admittedly it's from a number of different papers and different data sets, but they're all very large multi-center studies. The pre-hospital times as described by ground and air, ED time of 24 minutes, OR prep time of 14, and time in the OR for hemorrhage control is about 50 minutes. 128 minutes. 128 minutes from injury to operative hemorrhage control. But as we said already, the peak time to death is 15 to 30 minutes. So what are we going to do about this? So what are we going to do? Now we have this conundrum. And by the way, other people have talked about this conundrum. I think it's time to really lay it on the table and go, what are we going to do? Well, we can stop reckless behavior. I'll tell you, I have a 17-year-old son, and stopping reckless behavior is really hard. I try a lot, and we talk about it a lot, but dadgummit, he still does it. How about drive, fly faster to the hospital? We've been trying to do that for a long time. We might be able to shave a minute or two off, but I think we're pretty good at that right now in the U.S. Create more level 1 or 2 trauma centers, so you can create more of them so the drive and fly time is faster, though that's politically not very palatable these days and really expensive. How about run faster to the OR suite and the IR suite? I've been doing that for 30 years, and my times are getting slower rather than faster as I get older. How about change human physiology? And it's not there as a joke. I think there are people working on changing, why don't we put somebody in hibernation right away as soon as they get really injured? That's going to happen, but not in the next year or two. How about earlier abdominal hemorrhage control? How about earlier abdominal hemorrhage control? Rather than waiting to the operating room, why don't we move some interventions out of the operating room and combine that with pre-hospital plasma and or whole blood resuscitation? And this is kind of our wake-up slide here as we're in about 20 minutes or so. Insanity is doing the same thing over and over again, expecting different results. We've kind of done the same thing over and over again. You got the John Clark paper, and 20 years later, the John Harbin paper, showing exactly the same thing. It's time to do something different. And this may be a little bit of a tilting at windmills, with Don Quixote's book from the 1600s. But a couple years ago, hemostatic dressings and tourniquets and whole blood were considered not very popular, and people laughed at you when you kind of talked about them, but they've become pretty standard now. I think truncal hemorrhage control with dried plasma and whole blood at the scene or en route might just work and might fit into this category in a couple years. I have to talk about a little bit of anatomy here for just a second. My wife is an endocrinologist, and I love her to death, but she talks about the belly. There's a lot of stuff in there. The abdominal aorta for this discussion is divided in kind of zone 1 and zone 3. Zone 1 is above the celiac axis, so just above the diaphragm, but below the left subclavian. And zone 3 is above the aortic bifurcation, but below the lowest renal. So zone 1, zone 3 for the next couple slides. And Ron, again, published a paper last year looking at where bleeding happens. This is out of 4 trauma centers, 2 in San Antonio, 2 in Houston. And you can see that 72% of the patients who have big thoracic abdominal bleeding that's life-threatening, 72% occur in the abdomen and pelvis, and the majority of that is in the abdomen, not in the pelvis. And then Paul Cantel, a trauma fellow from Canada, who's now back up in Canada, has a paper that's accepted. And we looked at in the operative reports now in a single center and tried to determine where the bleeding site was from the operative notes. And fully greater than 90% of the patients were bleeding at sites that might have been controlled by zone 1, but not by zone 3. So if you put a clamp on at zone 3, you would have increased bleeding in 90% of the patients and only made it less than 10%. So the majority of the bleeding is above the aortic bifurcation in the abdomen. You need to know that because you got to start talking about interventions, and you don't want your intervention to make it worse. Like an extremity tourniquet, you don't want to put on below the bleeding site, right? Because you make the bleeding worse, you want to put it above. Same idea. So what are the potential interventions? Resuscitative thoracotomy. It's been done both in the ED for 50 years, but also been done pre-hospital. You know, kind of a pretty bold maneuver to do pre-hospital, but there are reports of pre-hospital thoracotomy. Roboa is a catheter, and I'll show pictures of this in a second, that goes in through the groin. You can blow it up in zone 1, zone 3 with a balloon. Abdominal aortic tourniquet puts on, it's a tourniquet that goes on the abdomen, squeezes your skin to your spine, and compresses the aorta at the aortic bifurcation. And rescue foam is an FDA, non-FDA cleared foam that's been cleared by the FDA to start their clinical trial, and that should start this year sometime. So in a year or so, we'll have some more information about that. It's kind of like Fix-A-Flat for your tire on your bike. You don't know where the hole is, you don't care, you just fill it up, stops the bleeding. Sounds crazy, right? But it's this is a bad problem. It hadn't been fixed in a long time, so maybe it's worse than crazy idea. So the ED thoracotomy you guys know about. You open the chest and you put a clamp on the aorta in that zone 1 area and stop the bleeding below. Pretty invasive procedures, understatement. The Roboa catheter goes in the common femoral artery in the groin, minimally invasive. I mean, you can blow that balloon up in either zone 1 or zone 3 to do exactly the same thing. This is, I think, an instructive slide from Baltimore and Houston. We introduced Roboa into both centers in about 2012 timeframe, and over the first 6 months, all the evaluable patients had ED thoracotomy. The second 6 months, Roboa started happening a little bit more, and then you see the two centers that over the last 6 months of this 18-month study that was published now 4 years ago, that the majority of patients who were amenable to this intervention were getting Roboa, not ED thoracotomy. So two groups that kind of voted with their feet and changed their practice pretty dramatically. The Roboa, as I said, goes in either zone 1 or zone 3 and is a catheter, 7-French catheter that goes through a 7-French sheath, 5-French catheter, and goes up and blows up the balloon to stop the bleeding. The Joint Trauma System, the military is deploying this technology on the battlefield and has written a guideline. You can download it from the Joint Trauma System website, and has been used extensively in Iraq and Afghanistan. Rescue foam, not FDA approved, will undergo their FDA cleared trial here very shortly, and is a big gun that you stick into the abdomen and fill the belly up with foam, and it stops bleeding in over 600 animal studies that have been published at least a dozen times. In the HAT, very little human data, approved for use, goes on kind of around your ASIS, and your belly button blows up and squishes your skin against your spine. Stop bleeding for that bleeding sites below the aortic bifurcation. All right, so how do we bring all this together? So this is kind of a little timeline I put together to try to summarize this. So this is what we do right now. You have injury to ED time, and then you go to the OR and you get hemostasis at 67 minutes, and the star is when hemorrhage control occurs, so 128 minutes. But the max time to death, as we showed earlier, is within 30 minutes. What if we moved that temporary hemorrhage control to the emergency department? Now, these are hypothetical. By any one of those methods, what would happen? Well, you might theoretically save 57% decrease in the time to hemorrhage control by moving that temporary hemorrhage control to the emergency department. And what if you moved it pre-hospital? Now, you still got to have the driving time and scene time and all that kind of stuff, but you might decrease time to temporary hemorrhage control by 100 minutes, or a 78% decrease. Now, there's that consistent curve of death again, and so this is where we are today with our current method of waiting until getting hemorrhage control in the emergency department. Then you said this is what where you might be on the curve if you moved hemorrhage control to the ED. And what happens if you moved it pre-hospital? Now, I'm not saying we're going to increase survival, but that is the curve repeated over and over again. It is related to hemorrhagic death. And the sooner we stop bleeding, the better off patients do. So what would happen to the patients if we stop bleeding here? We might improve survival. Now, what does that mean for the ICU? Well, in the war in Iraq and Afghanistan, we've done better pre-hospital than we did in previous wars. So it decreased the killed in action rate. It increased the severity of the injured patients arriving into the ICU. I think that that is absolutely a fact, and Dr. Chung and others have written about this in several areas. So if we're successful in decreasing hemorrhagic death pre-hospital, there's a large group of patients that I think are going to start arriving in the ICU with really severe injuries like we haven't seen before on the civilian side. That's what happened on the military side. And so I think we got to be prepared from a staffing point of view, a bed point of view, taking care of really seriously injured casualty point of view, if we're able to decrease, this part of the curve and shift more patients over to this part. So in conclusion, time to hemorrhagic death happens at a very consistent rate. It's remarkably consistent across studies, across interventional studies, over and over and over again. Death after travel laparotomy hasn't changed in 20 years. Up to 90% of the bleeding sites are in the abdomen and above the aortic bifurcation. Earlier hemorrhage control plus dry plasma and whole blood should improve outcomes. And even better if we can move out of the ED and into the pre-hospital area. And of course, lots of limitations to this somewhat hypothetical discussion with triage, personnel expertise, risk and benefits of proposed interventions. However, faster and more effective interventions in the hemorrhage control arena, both tourniquets and blood product resuscitation, have changed outcomes over the last 10 years. It's time now to set an audacious goal. I'm from Houston, right? So we put the space stuff up there. Why not push new interventions pre-hospital and stop truncal bleeding? Thank you very much for the opportunity to present the Peter Safar Lecture.